Good afternoon, everyone, and welcome to today's Fireside Chat. I'm Mamna Hussein, the Community Outreach and Engagement Manager at the Masonic Cancer Center here at the University of Minnesota, your host and moderator for our monthly Fireside Chats. The Fireside Chats are brought to you by the Office of Community Outreach and Engagement at the Masonic Cancer Center at the University of Minnesota. Our office serves as a vital bridge between the Cancer Center and communities across the state of Minnesota and beyond. Our small but very mighty team is committed to reducing the burden of cancer by actively engaging communities and providing access to relevant knowledge on the latest in cancer research, prevention strategies, the importance of screening and early detection, treatment options, survivorship, and opportunities for clinical research. Each month, we host these fireside chats to share knowledge, raise awareness, and highlight the people and research driving change across the cancer continuum. Today, in honor of Acute Myeloid Leukemia Awareness Month in June, we will be learning all about acute myeloid leukemia, also known as AML. AML is a fast-growing cancer that affects the blood and bone marrow. Because it develops rapidly, understanding the warning sign, the risk factors, when you need to go seek care, the treatment options, and also the advancements in research is critically important. And so today we will be exploring what AML is, who is at risk, how it's diagnosed and treated, and some of the exciting research underway at the University of Minnesota that is shaping the future of care. So to guide us through this discussion today, we are honored to be joined by a leading expert in the field, Dr. Zohar Sachs. Dr. Sachs has received her undergraduate degree in chemical engineering from MIT before earning both her MD and PhD through the Tufts Medical School Medical Scientist Training Program. She completed her residency in internal medicine and subsequently completed her fellowship in hematology, oncology, and transplantation at the University of Minnesota. Before joining faculty in 2012 as a physician scientist, Dr. Sachs built an internationally recognized research program focused on understanding the molecular mechanisms that drive AML. Her laboratory studies how leukemia cells survive and grow with the goal of identifying new treatment targets and developing new effective therapies for patients with high-risk disease. Dr. Sachs is also a research member at the Masonic Cancer Center and is part of the Genomics, Cell States, and Signaling Research Program. In addition to leading a highly innovative research program, she also specializes in care of patients with blood cancers, and so she brings such a unique perspective that bridges cutting-edge cancer research and patient care. So we are truly fortunate to have her guiding the conversation today. But before I pass things over to her, I would like to cover just a few quick housekeeping items. Today's Fireside Chat is recorded, as they always are, and will be made available on the Masonic Cancer Center's YouTube page by next week. Closed captioning is available for this session, and you can turn that on by clicking on the CC button that is on the bottom of your Zoom screen. For all University of Minnesota employees and spouses participating in the university's Employee Wellbeing Program, you can claim your 200 Wellbeing points for attending today's Fireside Chat by completing the form that will be dropped in the chat shortly. We also invite you to engage with us. So during Dr. Sachs's presentation, please use the Q&A feature at the bottom of your Zoom screen to submit questions that you have or any comments. We have time carved out at the end to take some questions. All right, I'm going to stop talking now and hand things over. So without any further ado, Dr. Sachs, the virtual floor is all yours.
Well, thank you so much for that. And thanks so much for having me here. I'm going to get my slides going here. And I really want to thank anyone, any members of the community that's here with us today. I really appreciate the opportunity to share this information, and I'm honored that you'll have me to do that. So we're talking about acute myeloid leukemia, AML, and I just wanted to give you an outline of what I was planning to talk about, and that way, if you have, some other things you were hoping to interject, you could think of those now. But I'm planning to talk about the definitions of AML, symptoms of it, risks for it, the diagnosis. We'll spend some time on the treatment course because I feel like that's the part that is maybe hard to appreciate. And then the new horizons, what we're doing here at the Cancer Center to help with this disease. Okay, acute myeloid leukemia, AML. So let's just define a few terms here. Leukemia is a cancer of blood cells. Myeloid just refers to a type of blood cell. There are other types of blood cells like lymphoid, but this is myeloid is just a type of blood cells. And acute, the acute part, because you may have heard of chronic leukemias. Acute leukemia refers to the number of immature cells that have accumulated. That's how we define it. But the reason it's called acute is because when you have a lot of immature cells accumulated, that correlates with a medical emergency, like acute clinical conditions and life-threatening complications. So that's what acute refers to. Leukemia originates in the bone marrow, but it can circulate in the blood. Okay, so we consider it a bone marrow cancer, which is different than a bone cancer. Okay, so we need a little bit of biology here, normal biology. Blood is made in the bone marrow, and blood has three major components. You have your white blood cells, which are your immune system. Your immune system is made up of white blood cells. Red blood cells carry oxygen to your tissues, and platelets allow your body to clot. When you cut yourself, platelets come and cause clots. So if you don't have platelets, you have bleeding, right? And as I said, blood is made in the bone marrow. And here, this image right here refers to, what these cells look like, basically. Okay. So the symptoms of AML are really tricky because they're, we'll kind of talk about these symptoms. They're pretty vague, and you probably think to yourself as I show you these that you probably had most of these in your life, and many of us have not had leukemia, right? So fever, feeling tired, feeling cold, headaches, weight loss, like unexplained weight loss, loss of appetite, easy bleeding, easy bruising, vague pains like joint pains, bone pains, rash, and bleeding gums. So this is like a big list of things where most of these we probably wouldn't, think much of if we had them, right? But let's think about what causes these symptoms. There are two big categories of problems with AML. Number one is that you just have a lot of these immature cells accumulated, and when they accumulate in your tissues, they can cause damage or they can cause pain. And then when you have leukemia in the bone marrow, it actually interferes with the function of bone marrow, meaning your bone marrow isn't able to make the cells it's supposed to make. So it's not making your white blood cells. You don't have an immune system, you're immune suppressed, right? You get infections. If you don't make red blood cells, you are anemic, you feel tired, you feel short of breath. And if you don't have platelets, you bleed, right? So this is a pretty vague and large list of things that can go wrong, which is why these symptoms are so vague. So that's, I think, kind of scary, to a lot of my patients who are in remission and they're wondering what to look for to worry about relapse. I don't have anything very specific to give them. It's this kind of thing. But fortunately, AML is actually a very rare disease. So, if you have a fever and a headache, you probably aren't likely to be having AML. So that's a fortunate thing. And for most people who get AML, we don't understand why. Like we can't pick out a risk factor for most people. I'm just gonna adjust here so I can see better. But there are some things that increase your risk of getting AML. And one of the bigger ones that we worry about and think about is chemotherapy or radiation. And so who gets chemotherapy and radiation? Is patients with cancer. And so having had cancer and having certain treatments for your cancer puts you at a higher risk for AML, which I think is a real slap in the face, right, for our cancer survivors that they, have to face this. And again, luckily, this is a rare complication of chemotherapy or radiation, but it does happen. There are genetic predisposition syndromes. So some people have a higher risk of getting it because of the genes they inherited. And then smoking increases the risk, and exposure to certain environmental toxins also increases the risks. But these exposures, we think, even though they do increase your risk, they don't make the risk very high. So even, many people smoke and not that many get AML. Okay. So how is it diagnosed? It's pretty easy to notice that something is wrong. A patient, goes to the doctor because maybe they have fever or aren't feeling well for a while, and the doctor does a very simple, basic blood test called a complete blood count. And the blood count may not allow you to diagnose it, but the blood count will be abnormal in a patient with AML. So this is like a really that's a nice feature, is that it's kind of easy to pick out that something is wrong. Sometimes you can diagnose it from a blood count, but most of the time the blood count looks weird, and so we do a bone marrow biopsy, and that's the way to definitively diagnose it. And here I'm showing you a picture of what a normal bone marrow looks like. You see these like clear looking cells. These are your red blood cells. And then these like bigger, darker looking ones, those are your white blood cells. So these are the different cells of your immune system. And I don't know if you can tell these tiny little dark dots, these are your platelets. That's what prevents you from bleeding, right? And when you have acute leukemia, this is what the bone marrow looks like. You see far fewer red blood cells, and instead of this like wide variety of these white blood cells, you see kind of a monotonous sheet of these immature cells that are just kind of taking over the bone marrow. So you see these are immature white blood cells, and they're kind of taking over. And even if they're not a ton of them, as in this picture, just having them there prevents the bone marrow from doing its job. Okay, so what causes AML? AML, people say this sentence, which I think might be confusing sometimes, but AML is a genetic disease. And by genetic, I don't mean a disease you're born with. I mean a disease that comes along because something bad happened to your genes. So it happened after birth, after you develop. And for most people, most of the time, AML is a disease of adults, but there's damage to the DNA, and certain genetic abnormalities cause AML. Okay. And those genetic abnormalities can be at the level of a gene, like a single little mutation that changes a single gene. And it can be at the level of the whole DNA molecule, where an entire piece of the DNA is broken off or rearranged, something like that. So when it's like a whole DNA molecule that's injured, we call that a chromosomal abnormality, and that's kind of represented here. But sometimes it's just a single gene, and it can be a combination of those things. And these specific genetic abnormalities that we find in leukemia are used in like every step of the treatment. It's used to define and classify the AML subtype. It's used to predict treatment response, and also to choose specific treatments and specific drug targets. So we know a lot about the genetics of AML, and it really helps us at every stage. Okay. So treatment. AML is primarily treated with chemotherapy. We also have targeted therapy, so molecules that are designed to inhibit a specific pathway. We have quite a lot of those for AML. And we also have bone marrow transplant. So bone marrow transplant, right, is receiving the bone marrow from another patient or another person, individual, and receiving it into the patient. And the bone marrow transplant, what that accomplishes really is to transfer the immune system of a healthy individual into the leukemia patient. And that immune system from the healthy individual, in some cases, can eradicate the leukemia that's left in the patient. So bone marrow transplant really works as an immune therapy in AML. And it's, even though bone marrow transplant is really quite old at this point, I think it's celebrating something near its 50th birthday now as a treatment modality. It's actually the only type of immune therapy that actually works in AML that's FDA approved for AML. Anyway, and so the way the treatment, the choice of treatment that we use for AML, and also the way the course continues in AML, really depends on two things. And one of them, the big one, is the risk stratification. So the combination of genetic abnormalities tells us how to treat the patient, how to choose drugs and treatment regimens for the patient. And the other big contributor to us choosing a regimen is the patient fitness to receive intensive therapies. Basically, we need to use intense therapies to cure AML. And so that's actually a big determinant for us. Okay, so I want to talk about each of these types of therapies in a little more detail, and then we'll talk about how we choose them and how we use them. So chemotherapy, this is the oldest form of cancer therapy. And, unlike a lot of other cancers, chemotherapy can cure AML, and it can cure only the favorable risk AML. And for patients where it can't cure them, it can control AML for many months, usually not more than a few years, but it can control the disease. And chemotherapy works by killing rapidly dividing cells. And here I have some of the most common side effects of chemotherapy: loss of appetite, nausea, fatigue, hair loss. And then what I have here is a long list that you're not meant to be able to read, but the point here is that chemotherapy can cause so many, damage to all kinds of organs, skin rash. It's a very complicated and long list of things that chemotherapy can and frequently does do. So it's a pretty toxic regimen, but as I said, it can cure leukemia, it can cure AML in some cases. Okay. And we generally divide the chemotherapy regimens that we use in AML into intense and non-intensive regimens. We classify them in this way. And the intense regimens are, really very toxic. And for that reason, they are only given in an inpatient stay. A patient has to come into the hospital to receive these treatments. And it's delivered, administered by very specialized nurses, expert nurses. There's a whole team of pharmacists that prepare these. And it's only like overseen by experts in the field, like I attend on the leukemia service to provide patients these treatments. But they are potentially curative, and they're also like a limited course. You go into the hospital, you receive your treatment, you stay there, usually about a month to recover. But then that's it, you're done. Okay. Non-intense chemotherapy is also toxic, but like far less toxic, less likely to cause organ damage. And that can be given in the clinic. So a patient sleeps in their own bed, comes into the infusion clinic, receives treatment, and then goes home. It's usually not curative. So we don't expect that it will cure leukemia. And usually these non-intense regimens are kind of repeated indefinitely. So you go into the clinic for several days every month and you receive these. I should say, actually, I should open my brain a little bit. Some of these regimens are starting to be developed into oral regimens where you can just take a pill and not come into the clinic. These are becoming a possibility, but you end up having to go to the clinic anyway for lab tests and other things. So anyway, so this is kind of how we treat with chemotherapy. We also have targeted drugs, targeted therapy in AML. And as I mentioned before, a targeted therapy is usually like a small molecule. Sometimes it's an antibody or a large protein molecule, but it is designed to interact with and interfere with the function of a damaged molecule, usually a molecule that is damaged by a genetic alteration, and then causes the cancer. So anyway, so it interferes with the functioning of these molecules, or a targeted therapy can just attach to a damaged molecule on a cell, on a cancer cell, and kind of be used as a label to say anything labeled with this molecule should be thrown away, should be degraded or destroyed. These targeted therapies can also act as kind of like a label as to what cells the body should throw away, and that actually works sometimes. I do want to point out one thing that's really, I think, very exciting, and this is probably a huge contributor to why I treat, why I'm interested in treating AML, um, aside from many other reasons. But this list right here is the list of targeted therapies that have been FDA approved for the treatment of AML in the last 8 years or so. And when I first started taking care of specializing in AML, it was closer to like 14 years ago. And at that time, I I had zero targeted therapies for AML. There was nothing on this list. And that was true for the first like 6 or 7 years. And it was that I was practicing in this field. And also it was true for the previous like many decades in AML. And so it's been incredibly rewarding and exciting to see all of these targeted therapies come really only in the last 8 years or so, FDA approved targeted therapies for AML. And each one of these represents years of work in a lab, a basic science and a translational science lab to develop these drugs. And these drugs are helping people. They're helping people to live longer and to live healthier lives. So for me, this is super exciting. As a scientist and a physician, this list is really exciting. Okay, and then we'll move on to the last type of treatment that we have, which is hematopoietic stem cell transplant. And there are two kinds of stem cell transplants, auto transplant and allogeneic. And I only bring it up because I think it's a little confusing sometimes, but we don't use auto transplant in AML because it doesn't work. An auto transplant is when we take your own bone marrow, a patient's own bone marrow, pick out the stem cells and give the patient like lots and lots of chemotherapy to kill off the cancer and then put the stem cells back. So an auto transplant is just a way to rescue your bone marrow and allow us to give really, really high doses of chemotherapy and then just give you a bone marrow back because you need a bone marrow. Allogeneic transplant refers to receiving the bone marrow from another person. And the real value of that is that you have a good functioning immune system. Like your own immune system has already shown us that it's not working to cure this AML, so we need a new immune system. So it's similar process. It sounds similar, but really the work of why it works is different in these two. And we only do allogeneic, meaning a donor transplant for AML. Okay. And so I wanted to spend a little bit of time on what the treatment course actually looks like. Okay. And we'll start off with the idealized situation, which is the AML course for a patient who has got favorable risk disease, meaning the genetic alterations of their leukemia predicts that they can be cured with chemotherapy. All right. There aren't that many of them. This is about probably a third of adult AMLs fit into this category. And also if a patient is fit. So we have a patient with favorable risk AML and the patient is fit and healthy and can take intense chemotherapy. So when that happens, here's like a little time course, right? Patient is diagnosed, we bring him into the hospital and we give them a course of intense chemotherapy. And they're in the hospital for about a month until they recover from that. During this time, they probably have fevers, they probably have infections, they probably have many, many blood transfusions, and many other things go wrong. Maybe they have some kidney damage, some rash, they lose their appetite, they don't feel good, their stomach hurts. All these different things, so many different things can go wrong, but that's why they're in the hospital. We have a dedicated and highly expert team to help them through this, to support them through this. And at the end of the month, they recover, the bone marrow usually recovers, and they can go home, but they don't get to be home very much because now they need to come in for more chemotherapy. Now, if the first round of chemotherapy did its job and the patient is in remission, meaning the bone marrow looks good, we don't see any evidence of leukemia, At that point, even though we don't see evidence of leukemia and we call it remission, we're not calling it cure because we know that even that after a single course of chemotherapy, even if we can't find the leukemia there, we know it will come back if we don't give more chemotherapy. And so what we do then is bring a patient back in for just a few days this time. We're only in the hospital a few days to get the chemotherapy, and then they go home and they sort of recover from that at home. And during this time after the chemotherapy, they have to come into the clinic, I would say a minimum of twice a week, usually 3 times a week. We check their labs, we check how they're feeling. They probably need transfusions. The risk of readmission to the hospital for an infection or something is pretty high at this point. But we kind of, again, we have a dedicated team of clinic staff and physicians and nurses who take care and monitor these patients really very closely. And then they do it all over again. So they go through this like shorter course of hospitalization for chemotherapy and then frequent clinic visits. And we generally do 4 of these short course chemotherapies after the intense chemotherapy. So that's a total of 5 courses of chemotherapy, and a favorable risk AML can be cured with this plan. And I would say something in the neighborhood of 60 to 70% of favorable risk patients who go through this can be cured. So that's exciting when that happens, when we have patients who can go through this. Every now and then we have a patient who goes through all of this without being admitted to the hospital again, but I would say that is a rare patient. Most of the time there are complications along the way. And this is the best case scenario, right? Now, for a unfavorable risk, so not favorable risk patient who is fit, who can take intense chemotherapy, but the gene alterations in their leukemia are not favorable risk, we don't think that we can cure them with chemotherapy alone, right? So we bring them in, the beginning looks the same, they're diagnosed, they're brought into the hospital, they get intense chemotherapy. Oftentimes that intense chemotherapy doesn't work. Their bone marrow does not go into remission. We have to repeat with another course of intense chemotherapy. Or at this point, depending on many, many things like what the leukemia is doing at this point, what the genetic alterations are, and also how the patient is doing at this point, we may choose a non-intense chemotherapy at this point. And here, the goal is just to get them into remission. If we are lucky enough to get them into remission with first round of chemotherapy, that's great. Or we keep going with, either another round of intense or go to non-intense, or we could do all 3. And the goal here is to get them into remission. Once they're in remission, then if it's not a favorable risk disease and the patient is fit, we recommend a bone marrow transplant. And this is another point that's and a bone marrow transplant is done inpatient. So they're in the hospital again here for another month, and then they're watched incredibly closely for another 3 months or so. Now, a bone marrow transplant works, as I said, by the immune system attacking the leukemia, but it really only works if we deliver a patient to the transplant without any detectable leukemia. So it's kind of it's confusing, right? Because you have to be in remission, so why do you need the transplant? But we know that when leukemia goes into remission, that just means you have a very low level of leukemia. It doesn't mean it's cured. And we know, especially for the not favorable risk disease patients, if we don't do a bone marrow transplant, these patients will eventually relapse. And so we get them into remission. We have to get them into remission, and then we go for a bone marrow transplant. And this approach for a non-favorable risk patient doing a bone marrow an allogeneic, right, a donor transplant can be curative. And this is what we do here is we cure patients, we get them to transplant, and we cure them with a transplant. So this is also another really exciting modality that we have available to us here. Okay, so what about patients who aren't fit for intense chemotherapy? And also, some people actually just choose not to, they don't want to go through what it takes to go through for intense chemotherapy. So a patient that's not fit for intense chemotherapy, we, at diagnosis, we give them this non-intense chemotherapy, and sometimes we do this first round in the hospital for a variety of reasons. But anyway, this is a patient that we try to keep at home. We don't plan to admit them to the hospital, but they're coming into the clinic also 2 to 3 times a week. And oftentimes they end up having unplanned admissions to the hospital for infections or other toxicities. And in general, we don't consider this regimen curative. So most of the time, these patients are not cured of their leukemia. And this is really, I think, the painful part. Um, when we're using non-intense chemotherapy, we can't really stop. We stop if a patient can't take it anymore, or if the leukemia, progresses. But as long as it's working, we kind of have to keep going. And this is really what's hard. It can be really, really hard on a patient to keep getting this chemotherapy, even though it's not intense. It's not that easy. So I consider this actually really pretty difficult to tolerate this forever, basically. Okay. And this is really the heartbreaking part of leukemia. The complications are really par for the course. I can never predict like which complication a patient is going to have, but I know that they're going to have complications. Most of them will have many complications. And even though I've been doing this now I've been on faculty now for almost 14 years. Patients never stop surprising me in the ways in which they can have complications, even though I'm expecting, and I've seen many kinds. So these are sort of the categories, right? Sometimes the therapy is just ineffective. We can't even get them into remission. And now we start this trial and error method of alternate chemotherapies, trying to get them on clinical trials. This is very heartbreaking because it's like the patient can't even catch a break. We can't get them in remission. As long as they're not in remission, usually the bone marrow is not working. So we're talking about transfusions, infections, and all of that. Even when a therapy works, just receiving this therapy really puts patients at risk of severe infections and having, frequent admissions to the hospital for treatment, for monitoring, for antibiotics. Organ damage is actually pretty common, and that leads to additional tests, additional procedures, a delay in therapy. Sometimes I have to wait until an organ gets better before I can use the therapy. So that's difficult. And sometimes this kind of organ damage can exclude the use of curative therapy. So if we give a patient a treatment and their kidneys are completely destroyed by the treatment, they can't have transplant. So that's also another big frustration for us. And then, of course, relapse. Relapse is always a heartbreaker. So these are the bummers of AML therapy, but they're also just so common. Okay. All right. So that's AML. But I do want to spend a little bit of time talking about what we're doing here at the Masonic Cancer Center, because I think that's the most exciting part, is what we're doing to make all of this better. I gave you that like long list of targeted therapies, and those are just so exciting, and it's so wonderful that we have those to offer our patients right now. But the fact is that those targeted therapies, none of them work for high risk AML. High risk AML is AML defined by those like very bad genetic alterations, and high risk AML is the type of AML that cancer survivors are more likely to have. So it's a particularly nasty kind of AML, and none of those targeted therapies work in this like high risk AML. And so one of the biggest, I would say, priorities for us, AML research at the Masonic Cancer Center, is to define drug targets for high-risk AML, a type of AML that currently has no targeted therapies available. And we talked about this, progression, the high-risk AML that develops in cancer patients. Sometimes that high-risk AML is preceded by a pre-leukemic condition. And so we are also working to prevent the progression of pre-leukemic conditions to AML. There are many labs working to harness the immune system in new ways, not just the bone marrow transplant that we have, to kill AML. And then also this, our university has a real long-standing strength in genetic engineering methods. So we're working on genetic engineering methods to make the immune system better at killing AML. And there's a really intense effort at the Masonic Cancer Center, also Masonic Cancer Center, to reach out to the community in new and innovative ways. So I think those are kind of the big topics I can think of. And I just wanted to tell you a little bit about what we're doing in my lab to address AML. So my lab is entirely devoted to understanding and defining treatments in high-risk AML. This is all my lab does. And I should just point out that our cancer center stands as a major referral center for high-risk AML. And so we're seeing a lot of those patients. And as I mentioned before, this is the AML with the worst gene mutations, and it's the AML that's common in, not common, but seen mostly in cancer survivors. And so we're, as I said, we're devoted to this type of AML. And our research, actually, we recently opened a clinical trial to treat these patients. So we're really very excited about this trial. And this is the only trial in the upper Midwest for this population. So I think it's a really important trial. And then another major area of research in my lab, and that's really in collaboration with a lot of Masonic Cancer Center labs. And we're working to define treatment targets to prevent the progression of this pre-leukemic condition to high-risk AML. And so I'll tell you a little bit more about each of these. So our approach to, so we wanted to study this high-risk AML, and our approach to that was to really apply some really advanced single-cell methods to analyze our patient samples. So as a referral center for these patients, we have a lot of these patient samples. We have a terrific sample bank that our patients have been generous enough to share their samples with us. And we have at the university some really incredible capabilities to do very advanced analyses. So we apply these analyses to our patient samples. And we actually found something, right? We found that high-risk AML depends on a very specific molecular pathway called NF-kappa B. And so we tested drugs that inhibit NF-kappa B and found that bortezomib, which is actually a really safe and non-toxic drug, can inhibit NF-kappa B and can be added to AML therapy. And that's what our clinical trial is. It's currently enrolling patients, both from our center, and we receive referrals from other centers to treat patients on this clinical trial, combining bortezomib to standard AML therapy. And actually, right now, there are centers across the country who have contacted us to try to open our trial at their center. And we're beyond excited about that possibility of trying to cure this AML with this discovery and to test it in as many patients as possible. So that's one area that we are working on. And the other area is a little bit earlier on. This is the project to prevent progression of pre-leukemia to AML in cancer survivor. Now, this is really hard. So you can pre-leukemia is a condition that it's hard to detect because, as the name implies, it happens in people who aren't sick, so it's hard to detect it. So it's really hard to study it in people. And so our collaborator, David Largesvada, developed a mouse model to study this. And we collaborated with him and basically identified critical molecular pathways that in this mouse model direct the progression of this pre-leukemic condition to AML. And then we checked whether those pathways that we discovered in the mouse model are also important in human samples, and we found that they are. And then we, in collaboration with Stephanie Wang's lab, applied an advanced artificial intelligence method that her lab developed to predict effective drug targets to these pathways. And we actually discovered a molecular pathway orchestrated by a protein called NRAS that seems to induce the progression of this high-risk pre-leukemia to leukemia. And we've identified some candidate drugs. And now we're testing these candidate drugs both in human samples and in the mouse model. And our hope is that we can identify some top candidates that we could test in high-risk patients with these conditions in the future. So that's kind of more in the future about where we're going. We also have many other labs at the university working on natural killer cells as a natural immune system cell that's potent at killing AML, and working to develop that as a viable treatment for AML. And then so that's the Miller, Felices, and Shihaki labs, and the Blazer, Allred, and McDonald Hyman labs are working to engineer and test new molecular targets for immune therapy. So we have many kind of approaches to try to treat AML and improve AML. And I just wanted to finish with this one last topic, which is the potential sources of disparities. I mean, I discussed with you some really intense therapies that we can provide, and we can help patients get through them. And a lot of patients do, and a lot of patients are cured, or a lot of patients live longer and are able to attend weddings, see grandchildren being born. It's beautiful and it's wonderful to see, but it's really hard. And this really does present some areas of disparities, right? If you don't have good access to primary care, your AML may not be diagnosed in time. If you have had bad experiences with the healthcare system, you may not be so willing to, trust us as we take you through all these things. Treatments are expensive, time consuming, they're debilitating. The best therapy is often through a clinical trial, and there are a lot of people who don't really have a lot of trust in those. And also these tests and treatments were sometimes really developed only in select populations, which means they may not be applicable to other populations. Anyway, I just wanted to mention that, but I'll stop talking now and see what you want me to talk about.
Thank you so much, Dr. Sachs, for that incredibly informative presentation. I really appreciated how you walked us through the entire AML journey, from understanding what it is, how it develops, and then also guiding us through the AML treatment course, and then sharing also all the exciting advancements that are happening right here at the Masonic Cancer Center at the University of Minnesota. So thank you for all of the work that you're leading in this space to improve patient outcomes. So we're now going to transition to the discussion portion of our session. So please continue to submit your questions using the Q&A feature. We've already received several great questions, and then we'll do our best to get through as many as we can in the time that we have remaining. But as most of you who've attended previous Fireside Chats know, not a Fireside Chat discussion until we get our campfire started, now that we're in the warmer month. So Dr. Sachs, I think I'm going to steal the share ability from you. Okay, and we have our fire started. Okay, so we have our very first question that I'm going to ask you. So somebody asked, do all patients undergo a lumbar infusion of chemo? And does this typically happen when they're in the hospital?
Yeah. So the lumbar puncture and providing chemotherapy through the lumbar puncture is not for every patient with AML. And I should say, I only treat adults with AML. AML is more common in adults, but children get it too. And I actually don't know the standard of care for children with AML. I do know that children are more likely to get AML in their central nervous system, and therefore might need these lumbar punctures more. But adults don't all need it. If you have other kinds of AML, other types of leukemia, acute lymphoblastic leukemia, ALL, everybody gets a lumbar puncture. In AML, not everyone gets it. A lumbar puncture, for those who might be wondering, is a way for us to sample the fluid around your brain, but it also is a way for us to deliver chemotherapy to that fluid. And so only in patients where we're worried about it for one reason or another, or only in patients who actually have the AML in their central nervous system, which is in adults not that common for AML.
Okay, so speaking of age, actually, there was a question that was submitted around, does a patient's age influence treatment options? And then, are there certain treatments that are more effective in younger adult patients that you see versus older ones?
Yeah. So again, I'll limit my answer to adults in general. I mean, kids always have better outcomes relative to adults for AML. So the cure rates are much higher in kids. And for adults, for kind of every decade of life, the right, so 40s, 50s, 60s year old, for every decade of age, not life, I should say, for every decade of age, the likelihood of being cured of the leukemia goes down. Okay. So age makes a huge difference in your prognosis. And it does make a difference. Is that because they're not responding to therapy as well? We're not actually exactly sure what it is about age, but we do know that as a patient gets older, it becomes harder and harder to give the intensive regimens. We, generally a patient in their 70s is going to make me think really hard about whether to give them intensive regimens, right? Like a healthy 75-year-old that's a difficult choice. Whereas like it's, in their 60s, I would probably give it without thought. And then once a patient reaches 80, I would be very reluctant to give intense therapy. So it makes a difference in those like higher age groups. Um, yeah, I think that's did I miss any point there? I don't know if there was more to the question. I don't remember.
That was it. So thank you for answering that. It was really just about if a person's age influences treatment options. So you addressed that question. So you talked in your final slide about disparities. You talked about access to care, the time of diagnosis as well. So, what are healthcare systems doing to address some of these social determinants of health around getting a patient once they're diagnosed? Right before we got on the call, you had shared that you have patients who struggle to keep up with treatments because they're expected to come in multiple times a week.
Yeah, that's a really good question. And I know at our cancer center, I can't speak for, systems in general. Our cancer center has a whole team of people whose job it is to reach out to the patient and like meet the patient at what they need, right? So I think one of the easiest things that we've done is that we have a lot of partner institutions. So if I am your doctor and I'm here at the Masonic Cancer Center, but you want an infusion in Princeton or Maple, Grove or something, we have a lot of other sites. So you don't have to come here. But we also have a whole team of people whose job it is to either help you navigate your insurance company, or here in Minnesota, if you don't have insurance, they can get you Minnesota insurance. And so that's available to a lot of patients. And we have people who will help our patients do that so they don't have to navigate that on their own. And then on top of it, we have experts at finding these grants. I had a patient come to me once because his insurance wouldn't cover whatever it is that he needed. I don't even remember. But like I just got our team on like getting the guy his grant. He didn't, he lived far away. He didn't want to have to come here again. And he didn't need to because all he needed was like this pathway to get his medication. And so we have a huge, infrastructure to help people in our system. Unfortunately, it doesn't help a person walk in the door. But
Mhm.
once they're in our system, we do what we can to like accommodate what they need, um, more than just the clinical stuff.
Okay, that's awesome and so good to hear that here at the university, these resources are set up to ensure that patients are any external factors are not affecting their treatment and their outcomes. So we have a comment that was just dropped. This attendee shared that their husband was cured of AML over 15 years ago via clinical trial at the University of Minnesota. And so just, thanks you for all of your hard work. And I think this is a really good way to segue about the importance of clinical trials. So you talked about some of the clinical research and studies that are happening that you're leading around AML at the Cancer Center. So what do you want community members to know about why it's so important to participate in a clinical trial or at least consider it as a treatment option?
Yeah, that's a really good point. I mean, in AML, the clinical trials that we have, we only open really it's important to participate in clinical trials because you know it's good for society, blah, blah. But like in AML, the only clinical trials we have are ones that we really think are likely to improve outcomes. Like we don't have any clinical trials where we're like, oh yeah, you might as well try. Like the
Mhm.
trials we open are either the data is also either so convincing that we think it's very likely to improve outcomes, or the options, the standard of care options are so poor that we have to do something better. Like we know that if we don't enroll like the high risk leukemia that I treat, it's incurable. People don't
Mm.
survive. We know that standard of care is not good enough. So a clinical trial is really an opportunity for a patient to try something that might work better than standard of care because standard of care is so bad. So in AML, at least, the clinical trials that we have are generally an opportunity. I think of them as an opportunity for the patients to receive better care.
Okay. I think I remember a while ago, I heard a saying that clinical trials are tomorrow's treatments today, right?
Absolutely,
And
of course.
so
Yeah.
yep. And so when the standard of care is no longer an option, then, a clinical trial is something that should be heavily considered. And so I do want to make a plug then. If anyone is interested in learning more about AML research studies at the University of Minnesota, the Cancer Center does have a cancer information nurse line, and it is a wonderful resource. I will make sure to include it in the email that will go out tomorrow, but you can call the nurse line. It's staffed by a clinical research nurse, or email ccinfo at umn.edu to get connected directly to the nurse to answer any questions or help connect you to available resources as well as the studies. Okay, this is more of a personal reflection question, Dr. Sachs. So, as both a physician and a scientist, what keeps you hopeful about the future of AML treatment?
Yeah, I mean, I think that that list that I showed you, this long list of targeted therapies, that like each one of those was a group of researchers working in a lab, figuring something out and bringing it all the way to a clinical trial that was successful. Um, I think as a scientist, it's amazing, right? Especially because I think nothing came up until 2018. I mean, that means I was in this field. I started medical school in 1996, 1996. I was in this field for like almost 20 years before we had a single targeted drugs for AML. And all that
Wow.
time I was doing research because I believed that it could help us. And then it did. And then it just feels like it helps and helps and helps. And like we get newer drugs. And people who, when I started practicing, had incurable AML now can be cured of their disease with these new drugs. It's so it the recent history is of how successful science has been is what
Mhm.
keeps me the most optimistic for the future.
That's amazing. Thank you for sharing that. So there was a question that was just dropped. So you mentioned that AML is a genetic disease. So this means that AML is caused by DNA damage. Can you distinguish between a spontaneous case of AML versus a familial case, if that exists? And also, actually, I'll let you answer this first question and then I'll
Yeah,
continue
that's a
on.
really good point. Yeah, familial. So familial would be the what we describe as genetic predisposition syndromes. So you inherit a gene, maybe your mom or dad has that gene, maybe some of your siblings have the gene. And the confusing thing, and I'm not sure if people know this, you can have a cancer gene, a gene that increases your risk of having cancer and never get cancer. So these genes don't like give you cancer. They just increase your risk of it. And some of the genes can increase your risk of breast cancer, prostate cancer, colon cancer, and AML, for example. And so, like BRCA1 and 2, which I think a lot of people know about and we think of
Mhm.
mostly as a breast cancer gene, it also increases your risk of AML, but like not that much. So
Mhm.
not that many people with that gene get AML, but it is considered a genetic predisposition gene. And can we tell the difference? We can, except we have to go looking for it. We have to think because it's a different set of tests, whether we look for the genes that are like, are damaged in your AML is a very different set of tests than the genes that are damaged that you were born with. So we can tell the difference, but we have to do the test in order to find it.
Okay, I'm going to continue on with this question. So for cancer survivors, you mentioned that they're at increased risk of AML because of chemotherapy. Is there increased risk because of DNA damage from previous therapy, or is it possible that there is some kind of DNA repair mechanism in cancer survivors that made them at risk of their previously treated cancer as well as AML?
That's a very, very good question. And both of those things are true. And also, what we think for AML actually is we think that those precursor, like those pre-leukemic cells, that we think that we are all developing these pre-leukemic cells in our bone marrow all the time. So it's not that chemotherapy causes us to develop them, we have them. And
Mm,
our immune system or something is really good at getting rid of them. And so we're constantly like developing them and then they die off. And what we think is that when you get chemotherapy, those cells have an advantage and they can survive through chemotherapy. And then that allows them, it kind of allows them to sort of survive and then grow. And so we're not exactly sure how they, what it is about
mhm,
chemotherapy that allows that, but we think it's more that the chemotherapy damages the bone marrow in a way that it allows those bad clones to progress. And there is quite a lot of evidence to suggest that is the case rather than chemotherapy damage to the DNA, at least in adults. In children, we think it might be more that the chemotherapy damaged the DNA and therefore caused the leukemia. So we think there might be both mechanisms at play, but the more common mechanism is this other one, the damage to the
mhm.
environment.
Okay. Okay. So one last question before we wrap up. Dr. Shax, we would love to hear from you. What is one key takeaway that you hope our audience leaves with today?
Well, you've given
I
me
know
this
we've
one.
talked about
Obviously,
this.
this is an obvious one. Um, Research is the only way to help our patients. It is without research, we can't do any of this. We can't help anyone.
Yes.
We need research in order to cure these diseases.
Yes. And that's why science matters and research matters. So, what a beautiful way to close our conversation today. Dr. Shax, thank you so much for sharing your expertise and helping us better understand AML and all the incredible advancements that are taking place in treatment and research. Before we log off, I have just a few quick reminders. Please take just a few moments to complete a very brief survey that will auto-populate when the webinar closes today. And then this survey will also be included in the follow-up email that we will be sending out tomorrow. Your feedback truly helps us continue to improve the series and to bring you timely and relevant topics. And as a thank you for completing the survey, you also have the opportunity to enter a drawing for a Masonic Cancer Center prize pack. Don't close the survey window after you hit submit because the link to enter the drawing will be made available after you submit the survey. We also want to let everybody know that we're taking a brief pause in July, so we will not have a fireside chat in July. However, we'll be back in August, same time, same place on Thursday, August 27th from 1 to 2. The topic that we will be covering has generated tremendous public interest. We will be talking about GLP-1 medications and cancer. And so we'll explore what the research is currently showing around how these medications impact cancer risk and outcomes. And so registration information for that fireside chat will come out soon. And the best way to stay informed is by subscribing to the Masonic Cancer Center's monthly newsletter. The link to subscribe will also be sent in the email that will be sent out tomorrow. Thank you again, everyone, for spending your afternoon with us. We truly appreciate the time and engagement, all of the wonderful questions that you submitted. We hope you have a wonderful rest of your day, and we look forward to see you in August. Take care, everyone.
Thank
Bye-bye.
you. Bye.